Welcome everyone. My name is Martyin, and I would like to present to you my PhD topic, which is new insights into the application of teledermatology. I'm a medical doctor and a second-year PhD student at the Department of Dermatology, Venerology, and Dermato-Oncology at Semmelweis University. My vision is that the latest technological improvements should be implemented in patient care as soon as possible. Therefore, with my team, we are working on providing reliable data in order to facilitate the widespread use of teledermatology. I currently have two ongoing projects. Both are systematic reviews and meta-analysis. So let me jump to my first project, which is comparing the diagnostic accuracy of teledermatology systems to face-to-face examination in the diagnosis of skin diseases. So up to 3 billion people in the world lack appropriate care for their skin diseases worldwide, and the incidence of skin diseases is rising with a projected increase of 12% in demand for dermatological services by 2036. There's a shortage and maldistribution of dermatologists. The shortage can be easily seen by the number of dermatologists per 100,000 people. This number is 7 in Germany, 3.4 in the USA, 0.7 in Indonesia, and in rural sub-Saharan countries, it can be less than 1 dermatologist per 1 million people. Although the shortage of dermatologists weighs the heaviest on low-income countries, the middle and high-income countries also experience the maldistribution of dermatologists. Teledermatology can offer a cost-effective and scalable solution. In the USA, an average in-person dermatology visit costs more than $300 while teledermatology visits cost significantly less, approximately $40. The most easily applicable approach of teledermatology would be the direct store and forward method, where the patient directly contacts the dermatologist, and this connection is separated by time and space. The problem which has limited the use of teledermatology so far were the technological and human resource demands, and also there was no established evidence on the reliability of the different methods of teledermatology. So our aim with this project was to assess the reliability of different teledermatology methods compared to in-person examinations. Our clinical question is whether teledermatology systems are as reliable as face-to-face examinations. We examined patients with any kind of dermatological diseases. The intervention was diagnosis via teledermatology, which was compared to diagnosis via face-to-face examination. Our primary outcomes were assessing the diagnostic accuracy through Cohen's kappa, specificity, sensitivity, PPV, and PV. The secondary outcomes included inter-rater agreement, diagnostic time, and satisfaction. Our hypothesis is that teledermatology systems have non-inferior diagnostic accuracy to face-to-face examinations. We conducted a systematic search, and we ended up with more than 150 articles. We established 3 different disease categories: the all skin conditions group, the skin cancers group, and the pigmented lesions, and we conducted different subgroupings in these 3 disease categories. So let me present my first forest plots. We examined the diagnostic concordance in the all skin conditions group, and first we made a subgrouping based on the communication platform. So we compared the store and forward, the real-time, and the hybrid methods. All the communication platforms achieved high diagnostic concordance, and there was no statistical or clinically significant difference between the platforms. So we can say that the least resource-heavy method, the store and forward method, achieved as high diagnostic concordance as the other platforms. On the second subgrouping, we looked at the communication types. So we compared the indirect and the direct methods of communication, and we can say the same. The diagnostic concordance was high, and there was no difference between the groups. We also looked at the use of dermoscopy in the skin cancer and pigmented lesions groups. In the skin cancer group, we observed that the use of dermoscopy significantly, statistically and clinically significantly, improved the diagnostic concordance. In case of pigmented lesions, dermoscopy did not have this significant effect on the diagnostic concordance. I would also like to present you the secondary outcomes. The inter-rater agreement was high both in the case of teledermatology and face-to-face examination, and there was no difference between the two groups. Patient satisfaction was very high. It was 82%. So 82% of the patients reported satisfaction with their teledermatology experience. We also looked at the diagnostic time in teledermatology, and we found that approximately 1 minute was needed for diagnosis in teledermatology. So the strengths of our analysis include that this is the first comprehensive meta-analysis which investigates all types of teledermatological care. We operated with a very large sample size. We examined almost 20,000 cases, and we involved data from all around the world. Of course, there are some limitations which lie in the diverse study settings and the different reporting of outcomes. So our conclusion would be that teledermatology is suitable for the remote diagnosis of all skin conditions, including skin cancer screening. The direct store and forward method has comparable accuracy to the more resource-heavy methods, and the dermoscopy increases diagnostic accuracy in the diagnosis of skin cancers. Based on these results, the implementation of teledermatology would be needed to increase accessibility to patient care, especially in low-resource settings, and we can conclude that teledermatology is reliable even without dermoscopy. Further studies would need standardized reporting of outcomes and reporting of true positive, true negative, false positive, and false negative values. I just recently submitted this article to the Lancet Global Health Journal. And regarding my second project, which is investigating the diagnostic accuracy of artificial intelligence systems in the diagnosis of skin diseases. So 65% of all patients with dermatological problems only consult their general practitioner, so they are in need for real-time diagnostic support by possibly artificial intelligence systems. Artificial intelligence systems may augment dermatologists' capabilities, reduce waiting times, and enhance the diagnostic efficacy, which is needed because of the previously mentioned shortage and maldistribution of dermatologists. Our aim with this project is to determine the reliability of artificial intelligence systems and their role in the everyday practice. So the clinical question is whether artificial intelligence systems are suitable for making a diagnosis. We will look at patients with suspected skin cancer diagnosed by AI, which will be compared to the reference test of the gold standard diagnosis, and the diagnosis of interest will be skin cancer. Our hypothesis is that artificial intelligence systems have non-inferior diagnostic accuracy to dermatologists. The clinical implication would be the implementation of artificial intelligence systems to improve patient care. We are currently checking the feasibility of this project. So in summary, I have 2 ongoing projects, both related to the technological advancements of dermatology. Additionally to my studies here at the Center for Translational Medicine, I'm also a scientific methodology supervisor. I am involved in teaching at the dermatology clinic. I also participate in some clinical drug trials, and I also had a conference presentation. Thank you very much for your kind attention, and I would like to finish my presentation with the words of Marie Curie: "Nothing in life is to be feared, it is only to be understood." Thank you.
Congratulations on your wonderful progress. I had even 2 questions. My first question would be, in Hungary, do you know how many dermatologists are there approximately?
Yes, thank you for the question. It's approximately the same number as in Germany, so around 7 per 100,000 people.
Thank you. And my other question would be, how is the satisfaction of dermatologists in general with these teledermatology systems?
Thank you. So we actually try to statistically compare the satisfaction of teledermatologists, but unfortunately not enough data were available to do this. But generally we can say that in all the articles included, teledermatologists reported high satisfaction rates.
Thank you.
Thank you.
Congratulations for your presentation. I have a question regarding to your first project. I may have misunderstood it, but how is it possible to perform dermatoscopy via teledermatology?
So dermoscopy is mainly used in the indirect type of dermatology when additional healthcare provider is involved in the method. So maybe the general practitioner would have a dermoscope, which is very frequent in, for example, Australia, where the incidence of skin cancers is very high. So usually there the general practitioners have a dermoscope available and they can make some digital photos with that.
Thank you very much.
Thank you.
So thank you for your presentation. It was really good. I was just wondering that nowadays everyone has a smartphone in his or her pocket. Is there any difference or any information about that you need a specific photographic device like a camera, or is it enough to do a photo with a smartphone?
Thank you very much. This was actually one of the subgroupings that we made, but I just didn't have time to present it now. But we found that basically there is no difference between images made with smartphones or with digital cameras, which also further strengthens our conclusion that the patient-initiated teledermatology is suitable for making a diagnosis.
Thank you.
And also we also looked at if training is needed to capture the images, because some of the articles also examined whether training is needed. And we found that there's also no difference between groups where training was involved and where there was no training for image capturing.
Thank you.
Thank you.
Thank you for your presentation. My question is, which is more time-consuming for a dermatologist, to do the face-to-face way or the other way?
Thank you. This was also one of the outcomes we wanted to statistically analyze, the diagnostic time needed in a face-to-face examination, but unfortunately none of these included studies reported this. But based on previous literature, around 15 to 25 minutes would be needed for an ideal face-to-face examination. Of course, it can be less in the practice, but for an ideal visit, minimum 15 minutes would be needed.
Okay, thank you.
Thank you.
So you're not to fear from me, but hopefully you can understand my accent, as Marie Curie said. Thanks very much. That was great. In the meta-analysis of the telederm, did you make a distinction between lesions which are really very suitable for store and forward dermoscopic and rashes, inflammatory skin diseases, undifferentiated skin diseases? Or did you do it all together?
We actually looked at the different communication platforms in all three disease categories. So we looked at all skin conditions, which was every skin condition basically without any major exceptions, the skin cancers and the pigmented lesions, because this was the three disease categories we were able to examine statistically. And there was no difference regarding the communication platforms in either category.
There's no difference in the diagnostic concordance?
No, there was no difference. So not in the skin cancer group. We had preliminary hypothesis that maybe the store and forward technique would be better for skin cancers, but our results did not prove that.
Okay. It surprises me too. I would have had the same kind of prior hypothesis that you would have had, because it's relatively easy to photograph a lesion, once you get it focused and with some artificial intelligence on the phone improving that. But it's quite difficult to photograph a rash that's all over the body that can and get it in focus and so on. And when we've done like telederm in my practice, that's always been the most challenging thing. It's just quicker sometimes just to, I know there's resource implications, but you get to a diagnosis a lot quicker when the patient's in front of you and you can have a dynamic history. Did these cases, did they have any other information, any other metadata around that, or was it just purely on images? Was there, age, duration of illness, symptoms, previous treatments? Were any of those included in that remote store and forward, or was it just a photograph?
In most of the studies, they also included clinical information, so history or probably some basic demographics too. Okay. So in most of the studies, they had some information, prior information about the patient.
So it wasn't really just a photograph. It was a whole kind of, maybe a family history of psoriasis or whatever.
Yeah, in most cases, yes. There were some studies where there were no clinical information included, but most of the studies included clinical information, clinical history.
And on the dermatology side, when you're in the clinic or in your virtual clinic, if you like, you've got an afternoon, Tuesday afternoon, and you're on the telederm, do you think you get through more patients there than if the patients are in front of you?
I think so, yes. But I think that it's very important to, I think for most people, if they would only do teledermatology, it would cause burnout very easily. Because I guess that physicians became physicians because they like to interact with patients. So only doing teledermatology would lead to burnout, in my opinion. But I think if someone only does teledermatology in a limited time, for example, for one day, I think it can be a very quick diagnosis-making process.
And then the following on of the management plan and the backup and so on, that I guess depends on the diagnosis completely, doesn't it? But there's not really any saving in that. It's just getting, because they, if they need surgery or if they need, methotrexate or a biologic, they're still going to have to attend the clinic. So it's just a screening thing. You're doing quite well in Hungary, though, 7 per 100,000. That's quite well provisioned for dermatology-wise. Do you think, what are the waiting lists or what are the capacity constraints with 7 per 100,000 dermatologists? What does that look like in Hungary for access?
I think there's also limited access in Hungary. I think in most middle or high-income countries, the problem is not the shortage, it's the maldistribution of dermatologists. So I think that it can be also seen in Hungary that the university cities or where the medical universities are placed, they have a lot more experts and specialists compared to the rural areas of Hungary. So I think that in the rural areas, also in Hungary, that would be beneficial to implement teledermatology.
So maybe, that urban-rural divide. And do you have a lot of dermatologists here go off and do cosmetic dermatology? Is that an issue with your 7 per 100,000? Or are they all doing real dermatology? Are they doing...
Yeah, that might also be an issue that a lot, not the majority, but a huge part of dermatologists are primarily in private care. So that might also contribute to the shortage or the limited access to care.
Yeah, it's a different type of maldistribution, isn't it? It's not just urban, rural, but people who are working in the big cities are maybe not necessarily seeing people who have got dermatological illness or severe dermatological illness or dermatological cancers and so on.
Yeah, definitely.
Yeah. So when will your paper be reviewed in Lancet? That sounds exciting.
I hope that soon.
Yeah, I do too.
But it was submitted last week, so I'm still patiently waiting.
Well, it hasn't been rejected already, so
Not
it's
yet,
kind of
not
good.
yet.
That's a positive.
Fingers crossed.
Thank you. Did I understand well that the only difference between face-to-face examination and teledermatology examination is that the physician sees the lesions or anything through the video or photo or in the room?
Yes, basically that's the difference.
Okay. And one more question. What was the measurement unit in your studies? The person, the patient, or the lesions?
The lesions.
Lesions.
We operated with the lesions, yes.
And did you account for it in the analysis that you could have several lesions from one?
Yes, that was
person?
accounted for.
And how?
I'm not sure, but I'm sure that it was accounted for.
Okay. Thanks.
Thank you.
My very tricky question, whether you are going to use artificial intelligence to study artificial intelligence in your second study, which is really tricky. I mean.
That's a very good question. So far, I'm not sure that whether there is an artificial intelligence model that would be reliable enough to use it in my meta-analysis. And also, there's some conflicting policies in journals about using AI. So that would require further thinking about the topic.
Yeah, I mean, this is also philosophical for all of us. I mean, that how much we use actually this and the different stages of not only at the searching and then also, but also in developing your paper and then drawing the conclusions. And so there's a big temptation, I have to say. But on the other side, I mean, from artificial intelligence, sometimes you get very crazy responses. So, I mean, you have to be very, very careful. So how does this come down to your clinical work?
The teledermatology topic?
Yeah.
I mean, there was already teledermatology system established here in Hungary during the COVID pandemic, and it operated with a very large data set, and it proved to be very successful and useful, but unfortunately, due to financial reasons, it had to be stopped. So now teledermatology is only available in private care. So I think that definitely the implementation of teledermatology could start here in Budapest, because the Hungarian people are also in need of access to appropriate dermatological care.
I know, I mean, I'm just telling to you that if you are a patient and you go to the dermatology clinic, I mean, there's such a big crowd, you see, because I mean, they are, of course, they are good experts, but they are overloaded. So the physicians themselves.
Thank you for your presentation. So regarding your first project, I was wondering if you have any idea of how many of those cases in the teledermatology, they need a further follow-up or the diagnosis is uncertain. Or would this cause additional cost for healthcare system? For example, you see a case that you're uncertain and then you ask the patient to come in person to do, for example, additional tests or biopsies?
Thank you for the question. So in most countries where teledermatology is implemented in the daily care, they use it as a triage or a screening, and it actually reduces the costs of healthcare, because if they can successfully triage these patients and also manage some of them remotely, then the number of the patients that actually go into the dermatology practice are lower. So, and the cost of teledermatology is significantly less than an in-person visit. So it's a very cost-effective solution.